Good morning, ladies and gentlemen. I would like to thank you for your kind attendance this morning. Instead of wandering in the sunny cities of this erotic city, you prefer to come to this hotel room seeking for knowledge. I would also like to thank the organizing committee for this very pleasant invitation. I accept it with sincere honor because I met old friends and tutors from movies like Prof to Fail. And taking this opportunity, I would like to congratulate also the organizing committee for this course, which is now is an institution, and sincerely tell them that they are both business success, as they have a day clinic which is the largest in northern Greece, probably one of the largest in Greece, but also apart the business success, they have doctors with high scientific caliber and clinical excellence, which is not very often.
Of course, we paid for this kind of advertising for Trifon, you know.
Yeah, I know. Thank you.
For an applause now, yes.
Paris, unfortunately, I wasn't paid enough from you, so I'm not going to carry on with that. So we're talking about the retinal vein occlusions. And as you know, the definition is an obstruction of one of the veins which drains the blood away from the retina. And it can lead to severe vision loss. And the classification is either central retinal vein occlusion, when the obstruction is of the central retinal vein, branch retinal vein occlusion, or hemiretinal vein occlusion, when it's about the two quadrants of the retina. In the BRVO, always we have, it happens in an arterial vein intersection. 99% the arterial is in front of the vein, and it never happens on inflammatory background. The percentage now of the types, 20% are CRVO and 80% are BRVOs. You can see here from the CRVOs that the 78% is non-ischemic, only 22% of CRVOs are ischemic, but 1 in 3 non-ischemic CRVO may progress to the ischemic type in 3 years. Also, from the ischemic CRVO, from different studies, 23 to 60% may lead to neovascular glaucoma in 12 months with new vessels in the iris, on the disc, or in the angle. The RVO, as you know, is the second most common sight-threatening vascular disorder after diabetic retinopathy, of course. It can be bilateral at a percentage of 10% at presentation. The prevalence of RVO increases with age, and it's not different between women and men. You can see here the prevalence of the RVO in Europe. And now the main reason for vision loss is the macular edema. We have changes in the blood flow, we have mechanical pressure in the blood vessels that lead to inflammation, and with the conjunction of inflammatory factors, leukocytes infiltration, increased vascular permeability and vascular remodeling, they all lead to the loss of the proper endothelium function and the formation of macular edema. Macular edema and neural cell death are the principal reasons for acute or chronic vision loss. And how this happens? The blood clot leads to disruption of blood flow, to intraluminal pressure, increased vessel damage, and this leads to hypoxia and ischemia. Hypoxia leads to an upregulation of VEGF, and the upregulation of VEGF leads to increased vascular permeability, thus the formation of macular edema. Inflammation and the reduction of the irrigation of the retina leads to neural cell death. Both the macular edema and the neural cell death, they lead to the chronic or acute vision loss of the patient. Now, these days, we have a new technology, angio-CT, and we tend to image everything with angio-CT. Now, from the angio-CT, you can see in the superficial capillary plexus, and mainly in the deep capillary plexus, the avascular zone disruption, which is very crucial for the outcome of the patient. And also, I don't know, they have a problem with the effects, you can see the areas of ischemia and microaneurysms. Of course, there are more numerous microaneurysms in the deep capillary plexus. Also, you can see the cysts and ischemia in this patient, and also you can see the vessel congestion. The vessel congestion always starts at the ischemia margin. It may lead to vascular remodeling, but it starts as only congestion at the ischemia margin. Here again, a patient that you can see the cysts and ischemia both in the superficial and deep capillary plexus. What is important, I'm sorry about the Greek, this is vessel congestion, of course. What is really important is that you see in a patient that receives treatments, you see the edema going down, but the ischemia is still there, and the vessel congestion is still there. The patient is not getting better, he just doesn't have fluid in the macula. You can see here the same thing. The patient has a lot of fluid, he's under anti-VEGF injections, and you can see that the patient, that the OCT get better. I'm sorry, you see that the patient gets better, but the retina is not. What does that mean? The blood flow disruption is not restored after the edema has been resolved. And that's the reason why we have the rebound phenomenon in vein occlusion more than anywhere else in the retina pathology. The edema recurrence actually takes place in the same ischemic area always. You can see the same things in the CRVO, ischemia, cysts, multiple macroaneurysms. Of course, they're more marked in the deep capillary plexus. And what these findings mean? We have a positive correlation of good flow density, both in the superficial capillary plexus and deep capillary plexus, with a good final visual acuity. But we have a negative correlation of the avascular zone disruption, mainly in the deep capillary plexus, with a final visual acuity outcome. Another prognostic factor for the visual acuity is that after treatment, the photoreceptors integrity plays a crucial role of the final VA. Now, what about the risk factors? I believe that this is the most important thing in the retinal vein occlusion management. It's not the treatment, you know the treatment, anti-VEGF or steroids, I don't want to talk about them, but this is a very important thing. RVO may be associated with ocular diseases, glaucoma, intraocular pressures, small eye, systemic diseases, diabetes, hypertension, hyperlipidemia, inflammatory diseases, sarcoidosis, syphilis, and the rest, and other various factors of the social life of the patient, smoking, obesity, obstructive sleep apnea. I wonder why I don't have a retinal vein occlusion up to now. And of course, we have younger patients that we have to be very careful about them. Hyperviscosity syndromes, coagulations, all the proteins, I don't want to talk about them. You can see the slide and you know about them. The myeloproliferative syndromes, Waldenstrom, of course, and hyperhomocysteine. What do you do with a patient like that? You try to manage lipids, hypertension, and diabetes. You refer him to a cardiologist. You do the vascular workup, and you try to manage the raised intraocular pressure, of course, if present. What we do in the University Eye Clinic, and I will show you later what they do at Moorfields. In the University Eye Clinic, this is what we do for all the patients. Blood, ESR, full blood count, cholesterol, urea, creatinine, electrolytes, ECG, and thyroid. That's for all patients. When we ask for more patients, if the patient doesn't have any risk factor, or if the patient comes with vein occlusion in both eyes, then we have to make an extensive history, look for tendency of thrombotic conditions, and try with a history and the ocular examination to guide you to your next level of workup. So what we do for selected patients, the one that I said before, we also do CRP, plasma homocysteine, thrombophilia screening, autoantibodies, AC, triplex, chest X-ray, and antibodies for syphilis. Concerning now the treatment points, you know about them, so I'll be very quick. We started with laser, we had too many clinical studies for that. Steroids, we're using triamcinolone for a long time in our life, now we're using Ozurdex. And then came the anti-VEGF era with too many clinical studies that support the use of anti-VEGF in the treatment of the RVO. And you know anti-VEGF, they work well, they reduce the edema, no need to underline that. Let's see this patient, 39 years old, good visual acuity the last 5 days. I'm sorry, the visual acuity was 3 out of 10 the last 5 days. The patient has a BRVO. She started anti-VEGF treatment. She did well after one injection. And then after the second injection, the visual acuity dropped and there was more cysts. This is the rebound phenomenon that I talked to you earlier about. And this is very common in RVO. But let's see this patient, 71 years old. He had a vein occlusion for 3 days. CRVO. You see not many fluid. He started injections. He He started very good, visual acuity was very good, but after 12 months and 10 injections, the visual acuity is worse, 3 out of 10, with no fluid. Why? We have restored anatomy, but we haven't restored the function. So what do? We always do a fluorescent angiogram to see what's going on. And with the FFA, you can see that this patient turned to ischemic type without macular edema. What we did, we tried to do a scatter laser, not very successful one, I would say. The vision get up to 4 out of 10, and then we carried on with injection. And today, 26 months after the incident, with 21 Lucentis injections, the vision is 2 out of 10. A crucial part of the response is the presence of ischemia. And always perform an FFA when the anatomical and functional findings are in disagreement. This is very crucial for the course of treatment. Now, there are some slides about the treatment. You know them, so I'm not going to waste a lot of time. First of all, assess the level of ischemia, identify the threatening factors. Okay, if the patient is non-ischemic in CRVO with a good VA, monitor. If the patient has ischemia or visual acuity below 10 out of 40, look for macular edema. If there is, treat with anti-VEGF or steroids. The same standings with ischemic. If the macula is perfused and there is macular edema, treat. If the macula is ischemic, again you treat. If there is macular edema, there's a big question to do laser or not. It's not supported by studies, I do it. And of course, if there is neovascularization, always perform PRP with the treatment. The same stands for BRVO. I'm not going to expand on that. You can see that in this slide. So if the visual acuity is good, if the visual acuity is bad, start with a loading dose of anti-VEGF. If the patient, after 4 injections, has no edema, observe. If there is still edema, carry on with anti-VEGF, and you can also do laser. Of course, you can change in any point in steroids if you think that the patient is not getting any better. The same stands for CRVO, with the difference, and you have to know that there is no reason to do laser for the macula after the initial course of injections. So you don't do grid or focal grid or any central laser in a patient with CRVO. It has no point. Now, I would like to show you a case of CRVO that we saw with Catherine Egan. Kathy Egan is a very well-known Murphy's consultant, has done a lot of work in veins. And look at this patient, a 41-year-old man. He came with a sudden loss of vision. He said that he had a vascular event with lots of painful lasers some years ago in a different hospital. And also, his father died at the age of 40. So you see the patient here. The visual acuity was 6 out of 24 in the left eye. We could not see the right eye. There was no view at all. He had a pressure of 39. This is the left eye condition. It's an obvious CRVO. And this is the investigation. Everything was normal, apart he had hemoglobin pathological. So we did all the investigations. The only thing was the hemoglobin and the mean cell volume. Is there anything else that you would think of, or you would treat this patient as just having a CRVO? Of course there is. The family history. The patient said that his father died suddenly at the age of 40. So you're thinking polycythemia. These are all the causes, the cause of polycythemia. I don't want to read them. You can read them from the slide. So what we did, we tried to find the notes from the other hospital for the other eye to see what has happened. And that's the original fluorescent angiogram of the right eye, and that's the periphery. So you see that he had a retinal angioma. Is that a truly isolated retinal hemangioma or a part of a von Hippel-Lindau disease? 30% of patients that have an isolated hemangioma have VHL. And is this VHL? Because VHL causes polycythemia and the patient didn't have any other factors for a CRVO. So we tested him, and unfortunately the patient had cerebellar spinal hemangioblastoma, renal cell carcinoma, renal cysts, and bilateral pheochromocytoma. The patient died 1 year and 2 months after the CRVO. The problem is that his 20-year-old daughter had this hemangioma and pheochromocytoma. She was operated for both pheochromocytomas. She was still alive when I left Moorfields. I don't know if she's still alive today. The problem with these patients is that they don't have the tumor suppressing gene. They create cancers all over their life. So how they investigate CRVO in Moorfields, not in Greece? They are very aggressive with the history, the medication, all the habits of the patient. They try to exclude glaucoma, and these are the tests. This is what they do at Moorfields for all patients. Blood pressure, full blood count, BSL, cholesterol, ESR, TFTs, electrophoresis, and ECG. That's a standard for all patients. If a patient is less than 50 years old, they check for thrombophilia, homocysteine, and antiphospholipid antibodies, and of course the inflammatory markers that you know about, ANCA, AC inhibitor, and rheumatoid factor. What is the thrombophilia screen? You have heard too many things. Antithrombin 3, we check that. Protein S, protein C, factor 5, Leiden. Are they relevant? Does that mean anything? If you find a tendency to thrombophilia, does it have anything to do with the CRVO? Or is it a common thing for other patients also? And you see that today we know factor 5, which we use to test all the patients, there are no studies to suggest any correlation. Only 2 studies, 6 studies said, no, factor 5 has nothing to do. Antithrombin 3, we used to check all the patients. There is no study with, that suggests an association of antithrombin 3 with CRVO. The same stands for protein S. There is one study that suggests no association. We say that, but we haven't proved that protein S has anything to do with CRVO. So what's the useful thing? Antiphospholipid antibodies, always check that in young patients. Homocysteine, always check that in young patients. And neither of these 2 factors were a part of the standard thrombophilial screening. The main things were out of the standard. So if you have also a positive test, don't cure it, don't give treatment, redo the test to be sure and refer the patient. When you're comfortable with a patient, if a patient is very old and has atherosclerotic factors, you are happy. Okay, old age and atherosclerosis gave him a CRVO. If a patient is less than 50 and has no factors, again you're happy. I have my guide, I do the whole test. If I find something, I'm okay. But what happens when you have patients older than 50 years old without atherosclerotic risk factors, and there are patients like that, or a young patient with atherosclerotic factors? Are you happy about that? Do they need to be investigated in a different way? The young guys that have atherosclerotic factors have to be investigated in a different way. It's not your job to do it, so it's not, but you have to refer the patient for that. So if somebody asks how to investigate CRVO, depends on age. If the patient is less than 50, do everything. If there is older than 50, do the basic things that I show you today. And finally, a very quick case. I don't know if I have time. Okay, I have 1 minute or 2, I presume. 72 years old patient. I don't want to waste time. He came. You see here a hemiretinal vein occlusion with lots of ischemia. All the area is ischemic. And this patient underwent laser, sectoral laser. And what happened with the laser, accidentally, I don't know if you know what that is. This is a chorioretinal venous anastomosis. We did it accidentally, but we used to treat patients like that. When you have a chorioretinal anastomosis, blood comes in a retrospective way. Blood from the choroid comes in the retina circulation and prevents, possibly, that was the theory, the development of ischemia. You lasered the vein, you broke the vessel wall, you had a rupture of the Bruch membrane, thus creating anastomosis with the choroid circulation, supposedly avoiding the development of ischemia in the patient. We don't do it anymore. I just want to show you that this happened accidentally, but we used to do that either with laser or surgically. They tried to do venipuncture, but of course there were intraretinal, subretinal, or vitreous hemorrhage. And there are other things that we have tried in the past, like Scythotomy. Paris and Solon and Thanasis are older, so they may remember the scythotomy. Of course, we have stopped all these things.
Over 50, so don't bother with us, we get a CRVO.
Professor Tsilibaris is older, but he was more far-headed and he didn't do scythotomy, I presume.
He's more understanding.
Okay, so this is what I had to show you. Hope you enjoyed the presentation. I'm open for questions. Thank you very much.
I think Trifon is the only guy who could be on the podium and a photo shoot happening outside and nobody noticing because he attracts all the attention. Trifon, I have a question for you. We see a different natural history of the neovascular glaucoma with the injection. So we used to say that this is a 100 days glaucoma, but now it's not uncommon that we inject the patient lives fine, and then a year after we finish treatment, he got back and he got a neovascular glaucoma. How do you try to avoid that?
How do we treat neovascular glaucoma?
How do you try to avoid first, and then if you want to say a few words about how...
To avoid neovascular glaucoma, you have to monitor the ischemia.
So you do a fluorescent angiography
always,
when they leave?
I always do a baseline fluorescent angiogram, both to identify any large areas of ischemia in the periphery that they're not visible, or in this case had a retinal angioma, or trying to investigate something else. So I always do a baseline FFA. It depends on the areas of ischemia if you decide to do any sectoral PRP or not. Now, if you have neovascular glaucoma, you asked me about anti-VEGF. Unfortunately, we don't have the licensed medication that we have. We cannot use them in neovascular glaucoma, but we all know for clinical experience, if you inject a patient with neovascular glaucoma, in 24 hours to 48 hours, he will come with no neovascularization in the iris or the angle. The neovascularization will disappear, and this will give you both the time and the window to do better PRP. So yes, I would inject a patient with neovascular glaucoma, definitely with anti-VEGF, and then perform lots of laser treatment, and always give the treatment to keep the eye comfortable with the known things, steroids, mid-relates, and things like that.
And one more question for Trifonas?
Trifona, thank you. Excellent talk. What do you think about the conclusions of the CRVO study, which, on the basis of differentiating ischemic with non-ischemic CRVO, recommended that really we should defer PRP laser until the onset of
Yes, we have overcome this study. This study was talking about how, first of all, you decide what really ischemia means or not. In the CRVO, they meant that ischemia was more than 10 disc diopters. So this is not, in these days, we don't use that anymore. We don't calculate the ischemic area and say this patient is not for treatment because of the large ischemia, and we'll just monitor him for neovascularization or something else. The era has changed. At the time, the study gave us some very hard guidelines to walk on. So it was very useful. So we knew that if the patient had ischemia more than 10 disc diopters, you shouldn't do some things. This has changed today, definitely. At least I don't use these guidelines anymore.
The point I was trying to make was that the CRVO study was probably not very well designed.
Oh, yeah, of course.
Because 13 disc diameters of ischemia is not an ischemic CRVO.
Yeah, that's what I said.
But I was pleased to say that, to see that you're actually a big fan of early fluorescein as well.
Definitely.
And for those CRVOs that have widespread ischemia, I think it would be a mistake not to do a PRP.
No. I do a PRP.
They will end up ending globiosis when the injection stops.
And if you saw the treatment plan, I put that, of course, I ran a bit quick through it. Even if it's not supported by studies, we do laser treatment in these large ischemic areas.
Okay.
Thank you.
Thank you, Trifonas. And we move on to the next speaker, Petros Aristodimou. On